Good morning, everybody. Welcome to our San Diego CFAR Research Day. It's my pleasure to introduce and welcome all of you to the morning. It's a very exciting day. One, I'm the co-director of our San Diego CFAR. My name is Davey Smith. You don't know me, and if you don't know me, make a point today to come up and at least introduce yourselves and we can chat. But I want to welcome all of our speakers. Thanks for coming far and wide from lots of different places all across the world to our research day to enlighten us about the research, great research that you're doing. It's also my pleasure to welcome our keynote speaker, Elba Saul. I'm very excited. We arranged everything around just so we can make sure to have her to talk, so we're all very excited to do that. I also wanted to thank our CFAR. Liz is taking a picture of me, and it's Liz's birthday today, so maybe should we all sing later? But it's I want to say thanks before I forget to all the people who helped in the CFAR office, Liz and Shauna and Diona and Kim and Bryna for putting all this together. I really want to thank you for that. It's also my privilege to introduce Jamila, Dr. Stockman, who's my friend and colleague. She's the Vice Chief of Global Public Health within the divisions of ID and Global Public Health here, so thank you. And she was instrumental in us getting our CFAR Disparities Core started. She's the director of our CFAR Disparities Core. And the good news is that we just got our score today for CFAR, and it's a 16, so that should be good enough to get funded. I am so happy. And I think one of the big reasons why we did so well is because of our new Disparities Score. So on that note, can I invite you to come up?
Oh, this is a little, okay. I'm short, so I can't even see you guys. Oh, this is awful. All right. Okay. So good morning, everyone. Today, I will be sharing with you the ongoing saga of disparities in HIV prevention and treatment. It's my hope that one day I'll be able to have another talk where we can say the end of disparities in HIV prevention and treatment, but until now, here we are. So I just want to preface my talk by stating that my presentation will focus on the U.S. HIV epidemic, because our keynote speaker, Dr. Elbasel, will speak about HIV in an international context. First, I would like to acknowledge the California HIV/AIDS Research Program. As Dr. Smith mentioned, we received funding from CHRP to establish and develop a disparities core within the CFAR. I'd also like to acknowledge a community partner, a local community partner that I've had the honor and pleasure of working with for the past 4 years, Christie's Place, specifically the executive director, Dr. Erin Falvey, and Jay Blount and Martha Robles, peer navigators at Christie's Place. And I'd also like to acknowledge a couple of my research team members, Kristen Gunderson, who functions as my program manager, who was instrumental in helping me pull together this presentation, and Ariacella Holdbrook-Smith, who provided assistance. In honor of World AIDS Day, a quote by President Obama has stuck with me since last year. He stated, "By shining a light on this issue and educating more communities about the importance of testing and treatment, we have saved and improved lives. Although we have come far in recent decades, our work is not yet done, and the urgency to intervene in this epidemic is critical." So indeed, we have come very far in recent decades, but we have a long way to go in terms of eliminating HIV-related disparities. We know that about 37 million people are now estimated to be living with HIV globally, and during 2016, 1.8 million people were newly infected, and there were 1 million HIV-related deaths. If we break the 37 million number down a little bit further, we know that about the majority of people living with HIV are in Africa, followed by 3.5 million and 3.3 million residing in Southeast Asia and the Americas, respectively. Turning our attention to home here in the US, 1.2 million people are living with HIV. There are about 40,000 new infections that were reported in 2015. The good news is that HIV incidence has declined overall. From 2008 to 2014, the estimated number of annual HIV infections in the US declined about 18%. We've seen decreases among some population groups, such as heterosexuals, people who inject drugs, and white MSM. However, only 55% of those diagnosed are virally suppressed. Here we turn our attention to the UNAIDS targets by 2020. So as all of you may know, our target is to hit 90-90-90 in terms of the proportion of individuals diagnosed. Of those diagnosed, the proportion on sustained antiretroviral therapy, and of those on antiretroviral therapy, those virally suppressed. And the red ribbon denotes the progress that we've made in the US thus far. So as you can see from this, we have a long way to go in terms of reaching the 90-90-90 targets. Furthermore, there are certain key populations at risk for, at higher risk for HIV in their lifetime. These groups include African American or Black men and women, as well as Hispanic men. When we look at these groups a bit further among ethnic minorities, we know that African American or Blacks make up 12% of the population in the United States, yet they account for 40% of people living with HIV. And regarding Hispanics, both men and women are 3 times more likely to be diagnosed with HIV than non-Hispanic white men and women. Related to MSM populations, Black and Hispanic Latino men accounted for 2/3 of all gay and bisexual men diagnosed with HIV in 2015. And what's striking on this slide, for me, what was striking is the 1 in 2 estimate. So what that means is that in a Black man's lifetime, he has 1 in 2 chance of becoming infected with HIV. It's also important to note that a group disproportionately affected among the MSM group is our youth, aged 13 to 24. Women are also at risk and disproportionately affected. 1 in 10 women living with HIV do not know they are infected, and the age group in which accounts for the majority of new HIV diagnoses among women is ages 25 to 39 years of age. And you can see from the map here that the prevalence of HIV among women is dispersed across the US, but higher in certain regions in the US, notably California, Texas, the southern region, and the Northeast. Specific to Black women, this is really disturbing in that Black women account for, although they represent 62% of women living with HIV, despite accounting for only 13% of the female population in the US. And since 2008, so we're looking at about approximately 10 years, Black women have consistently represented nearly 2/3 of all women diagnosed with HIV each year. Youth are also another group disproportionately affected. Youth aged 13 to 24 account for more than 1 in 5 new HIV diagnoses in 2014. And again, the geographic distribution of HIV incident cases among youth mirrors that of women and also African American Black individuals. And among youth, Black youth aged 13 to 24 have the highest HIV incidence rates. So in addition to these disproportionately affected population, we also have other marginalized populations that are at risk and infected with HIV. And they have been targeted in terms of intervention efforts. So intervention efforts have focused on these populations, but they must be continued in order to reduce the number of new infections and improve linkage and retention and care among these populations. So I've highlighted a few here: transgendered populations, people who inject drugs, female sex workers, and incarcerated populations. So in order for us to meet the reality of getting to zero, we must address the disparities and the underlying factors fueling these disparities among those most at risk for HIV, as well as those living with HIV. And now I'd like to turn our attention to a few of the missed opportunities. And I've just provided a snapshot here of some of the areas that I've noted through research of myself and others that fuel the disparities. So CDC released a report last week, coinciding with World AIDS Day, in which they highlighted that 7 in 10 people at risk, at high risk, who were not tested for HIV in the past year, saw a healthcare provider during that time. And more disturbing, more than 75% of them were not offered a test. So that's a huge missed opportunity in terms of our HIV testing outreach efforts. There are individual level barriers that affect women, men, all of the disproportionately affected populations from seeking an HIV test or being linked to care if HIV positive and remaining engaged in care. And some of these include lack of transportation, lack of health insurance coverage, high perceived costs and low perceived benefits of healthcare visits. So what that means is often people have competing priorities in their life, and whether it be tending to childcare or missing a day's worth of work, and that's a lot, and it can result in a significant financial impact on the household. So when an individual living with HIV is experiencing other life issues, there's a balancing act that goes on, and in terms of what is the perceived cost of me missing all of these things related to my life, my daily life activities, versus the benefit, the actual benefit of going to visit a healthcare provider. There's also a disclosure of sexual behavior to healthcare providers. That's often an issue, specifically among youth and transgendered populations, as well as MSM. Incarceration is another factor fueling disparities. HIV testing and prevention services are not widely accessible in correctional facilities, despite HIV prevalence rates that are approximately 5 times greater in prisons. I was shocked by this. Only 20 states test all inmates for HIV at admission or while in prison, and only 3 states test upon release. So we have a situation where the prevalence rates are significantly higher in correctional facilities, and we're missing that opportunity of testing individuals upon exit, upon release. There are also psychosocial syndemics that affect people at risk for HIV, as well as those living with HIV, including substance use, adverse mental health outcomes, violence, and trauma. And these issues often impede an individual's ability to be retained and engaged in HIV medical care treatment, as well as adhere to ART therapy, and ultimately achieve viral suppression. At the social and structural level, issues include HIV stigma and discrimination, medical mistrust, which is highly prevalent in the African American Black community, institutional racism, unstable housing, unemployment, residing in areas with low density of HIV prevention services. So there's areas throughout the United States where there lack of HIV prevention services. Not only are there lack of in-person HIV prevention and treatment facilities services, but there aren't even provisions allotted to account for or to have a mobile HIV testing van out in these areas to provide HIV prevention services. There's also providers' lack of cultural competency related to sexual identity. And this is particularly important when we think about youth, especially ethnic minority youth who are disproportionately affected by HIV with the high HIV incidence rates. Voluntary HIV testing is stigmatized in a lot of populations. We think that our social media campaigns and outreach efforts are helpful. Well, yes, they are to a certain extent, but there is still stigmatization that occurs when we think about voluntary HIV testing. So there are, on a positive note, there are innovative intervention approaches that are currently underway to tackle some of these underlying disparities and underlying issues fueling disparities. And so I want to highlight a few of them here. Technology, there's an abundance of mobile HIV prevention and treatment apps that have been implemented and demonstrated to be efficacious in terms of improving HIV prevention and treatment outcomes. There's also text message reminder systems that a number of research groups are implementing as a way to improve ART adherence. I have a photo here of a mobile app, and this mobile app is called Links. It was created by Ian Holloway and colleagues at UCLA, and it's a really innovative app that I'd like to talk a little bit about. So this app is designed for African American Black MSM populations in Los Angeles County. And this app does two things. It doesn't just address HIV prevention treatment. What it does, it addresses the social service issues affecting Black MSM. So it offers a peer coach. The peer coach is another Black MSM who they can self-identify with and feel comfortable communicating to the peer coach about the ongoing life stressors occurring. And some of these stressors include unemployment issues, legal issues, housing issues. So what this app does, it addresses these life issues as a way to get at underlying HIV treatment. And it's been well received among the Black MSM community in LA. It's demonstrated feasibility and acceptability, and he's currently in the process of testing this app in the form of an intervention to demonstrate efficacy. So this is very promising and where the field needs to be moving by integrating some of these underlying factors fueling disparities. Housing support has also been delivered as part of interventions and has been shown to facilitate linkage and retention in HIV care. Addressing syndemic conditions has also been identified by a number of researchers as critical in terms of improving HIV care outcomes. Some interventions have integrated mental health services into existing HIV service programs. And there's also an intervention led by myself, actually, and colleagues at Christie's Place, where we are linking women who experience some of these psychosocial syndemic barriers of domestic violence, mental health, adverse mental health, and substance use to support services outside that can tackle these issues, while also targeting their linkage to and retention in HIV medical care. So it's a twofold intervention. And finally, there's peer navigation that has been identified as a best practice model for integrated HIV models of care. And peer navigation can occur in multiple ways. Two of the methods in which peer navigation can be delivered is through via in person, or electronically, through mobile apps such as Links that I previously highlighted. Well, for some populations, in-person peer navigation is more effective. And an example of such a population would be women who are experiencing psychosocial syndemic conditions, such as mental health, adverse mental health, substance use, and domestic violence. And Christie's Place, our local nonprofit organization, they've been instrumental in implementing peer navigation approaches through different collaborations and even testing it in an intervention context. And so now I would like to highlight the importance of peer navigation. And here we have a photo of peer navigators at Christie's Place. And I've had the pleasure of working with 3 here on this picture. And, you know, peer navigators are women living with HIV who have overcome barriers themselves, helping other women living with HIV to overcome their barriers. So ultimately, there can be improvements in their HIV care outcomes. And these women are strong, resilient, vibrant, and just really role models to me. And so I'd like now for you all to have the pleasure of hearing from 2 of the peer navigators at Christie's Place, Jay Blount and Martha Robles. Please come on up. I consider Jay and Martha dear friends and colleagues. I've known both of them for about 3.5, going on 4 years now. And their stories are very impactful and insightful. So this morning, Jay and Martha will each share a portion of their life story with you and share some of the barriers that they've had to overcome. And then jointly, they'll discuss and share with you the great work that they're doing at Christie's Place. Thank you.
Thank you, Jamila. My name is Jay, and I am a peer navigator at Christie's Place. I'd like to share a little bit about my life. So I was diagnosed with AIDS in 1996, and was told at that time that I only had about 1 year to live. But getting to that diagnosis was hard because I got sick with a cold prior to diagnosis, and then I went through a phase where I couldn't eat or drink anything. So I would go to these different clinics because I didn't have medical insurance, and they told me I had a bad ulcer and would put me on antacids, even though they knew that I was a former prostitute and a former drug addict. So I did that about 3 times, and then finally I went to an emergency room after having an allergic reaction to an antibiotic, and this young doctor told me I had thrush and tested me for HIV, and that's how I found out that I was AIDS positive with 116 T cells. During that time, I tried to stay clean, but it was difficult and I didn't. I eventually relapsed. And going to the doctor, for me, in the town that I was in, there was no women with HIV. I was the only identified woman in my area, and that went to the service providers. So my hat's off to the gay white men that took care of me, but I didn't see anybody that looked like me in these agencies. Okay. So during my addiction, I was on and off meds. And then I had a discussion with my doctor to get off meds because I wasn't taking them properly. My substance use was strong. It was the most important thing that I had in my life. I didn't care because they had told me I was gonna die anyway, so I didn't care. So I did that for about 11 more years, and recently, about 11 years ago, I decided to change my life, and I got into a drug treatment program, and that was the change of my life because it got me back in medical care. I wanted to live. I figured out in 11 years that I wasn't gonna die. You know, it took me that long. So I decided I wanted to live. And I went through this drug treatment program, and I stayed there, did the whole program, and I started working for the program as a residential house manager for the women. But at this particular drug program, they had a program for HIV positive people. So we had our own support group, we had our own counselors, which was great. It helped with the questions that I had and all this stuff. So during my time at this drug treatment program, I heard about a place called Christie's Place. And so I went down, I enrolled in the program, still didn't know much about it, but I had heard about this retreat. And so I was all excited. I was like, oh, I've never been camping before. I've done in the woods, I've never done anything like that. So I was really excited to go. So I get to this camp, and this woman was doing a session, and she happened to be the executive director of Christie's Place. And I just fell in love. I was in awe at the things that she was talking about. It amazed me that when people without HIV cared so much about people with HIV. It just it blew my mind. And I met other women, and it was just a revelation, really, and it helped me decide for myself that I really wanted to work with people living with HIV. I didn't know how I was going to do it. I didn't know in what capacity, but I was going to do it. So a couple of years after that, I found out Christie's Place was hiring, and I got on it. I was on it. I called them, got my application faxed to me, and the same day I faxed my resume, the application, and was on the phone. That was my job. It was going to be my job. So I really bugged those people until they hired me. And they hired me as a peer navigator for this program called Change for Women. And being a peer navigator allows me to work with wonderful women who have major problems in their life. The barriers, they have so many. And it allows me to help this woman overcome being afraid to talk to her doctor. And we do that by practicing together, or going to the doctor's appointment with her, make sure she has her list. And, if she forgets something, remember you wanted to talk about this. And so we do it like that until she's strong enough and feel confident enough to be able to go to a doctor's appointment herself. We babysit at appointments if we need to. And it's tough because there's still the stigma women face, because we face stigma just being a woman. And to put on top of it HIV, then that's really a serious issue. And, some women are afraid to tell their family members that they're positive because of the backlash that they get. And so we talk about all of that. And, we just guide them. And, the agency I work for is the people just care. We care about our clients. We want the best for our clients. We want them to be the best people they can be. And Christie Place gave me an opportunity as being a client to become a part of the staff. So I was, it gave me that opportunity to work up to staff. And I'm not the only one. So I think that's about it. Thank you.
Good morning, everybody. My name is Martha, and I'm nervous. I'm just want to start by saying that I was diagnosed in 2000. As a Latina woman, I started, trying to be a good model in my home, be a good wife, and, a good mother. But everything, was not that good for me in that moment. And so very young, I started using alcohol. And when I got married, I was struggling so much in my relationship that I started using drugs in my own home. And one of the reasons that I was doing that, it was because I was not feeling okay with myself, and because I couldn't have a baby, right? I couldn't have kids. So I thought about relationships, they have to be, being a mother, having a family, right? And so because I wasn't able to be that or do that, I was struggling in my relationship a lot, and that's why I started using in my own home. So finally, when I was suffering a lot from domestic violence and trying to be somebody, one day I was just not feeling okay, and I was under the influence also. So I was scared because I was feeling something weird in my body, so I just decided to go and buy a pregnancy testing at the 99-cent store, and it came up positive, right? So because I was loaded, it was like, no, it was like incredible of me, how can I be pregnant? So I went to the CVS and bought a little bit more expensive pregnancy test, thinking that it was the pregnancy test that it was wrong. And I bought it and I got tested and it came up positive again. So for me, it was like thinking in that moment, everything is gonna change because now I'm gonna be a mother. I can make my partner happy. It was all about that in my life, not seeing my drug addiction in that moment. So when I see that pregnancy test that it came up positive, I decided to stop using that day and went to the clinic. And they did a lot of lab tests, and they told me that same day that I was pregnant, that I was 5 months pregnant, and that it was going to be a baby girl. So I was just very happy because now everything was going to be different. I'm not going to be drinking anymore, using drugs. Everything is going to change. It's a girl, so I have to protect her. And in that moment, it was, I don't care about what he thinks. All I think it was about that baby, right? Still struggling. 2 days after that, they called me from the clinic, and they told me that they can see that I was struggling with drug abuse. I said, no, I can stop at any time I want, even that I couldn't see that I was using already for, I don't know, maybe 20 years already, without noticing that I have that problem in my life. And then they also said, so we did all this testing on you, and you came up HIV positive. In that moment, I thought I was gonna die next day. When this person at the clinic was educating me about HIV, all I could think it was, I don't even hear her. I was just seeing those 3 letters on top of my head, like huge, and I'm gonna die next day. What do I have in my stomach? Just thinking that my life was done, right? And I thought I was the only one that it was positive. I wanted to kill myself after that. And for one reason or the other, I see God in my life, right? And I decided to change my life. They told me if you stop using drugs and start your HIV treatment, everything can come up, good. There's a possibility for your daughter to born negative to HIV. And even with that, not believing that, I decided to do it after all, right? Because I was so afraid to kill myself that I decided to change that and do what they told me. And I did it. It took me a while. I didn't do it right away because drug addiction, it's hard, right? And so I started going to the HIV treatment, and I stopped using. So after 4 months later, my daughter was born. But that night, before she was born, I got into a fight with my partner, and that night I decided to use. So when I went to the hospital, my daughter was born negative to HIV, but positive to crystal meth. So that's when CPS got involved, and they took my baby away. And that was awful. Calling me not a protector mother, it was something that, how can they say that about me? Because I'm a wonderful woman, I'm a real, respectful and good wife. So when they told me that and they took my baby away, it was like, for me thinking about, is it worth it to stay with this person or not do nothing about it? And they offered me the support, right? They offered me the NA programs and AA programs. So I say yes at the moment because I really want to get my baby back, and it was difficult, but I decided to do it. So 2 months later, I got my baby back. I got introduced into Narcotics Anonymous. I fight for myself and started, getting all this support, and they also offer me some support groups for positive women. And I started going to this program at another agency where I got educated and learned that I was not gonna die from this. And, but I still using by that time, because when my daughter was born after 2 months, I got her back, but I still using, right? And when I started working in the community as a peer advocate at this other agency, I learned that HIV, it's something huge in your life, but it doesn't kill you if you take care of yourself. So that's what I did. I learned, and then they offered me to work in the community and educate other women, and it was like, oh, this is nice, right? I like it. I like that I was able to tell other women that, you can prevent this. So I learned a lot. It took me like 3 years to kind of understand that I need to stop using, but I did it. There was a moment when I really decided to change my life and get rid of that person that it was like on top of me. And so in 3 days, I'm gonna turn 12 years clean, being part of NA program. So that's Narcotics Anonymous. So that's one of the best things that I could do for my life. And so now I just turned 17 years living with HIV. Not HIV, AIDS, because at the beginning when I couldn't stop using, instead of being HIV, I turned into AIDS. But I know it's still, because I'm educated now, I still know that I'm not gonna die from this if I do the right thing. So when I decided to change my life, I also decided to educate myself more and help other women in the community. That was like one of my biggest goals. Why? Because I got my daughter and I wanted to change that. I want to give that example for my daughter because she's a woman, right? So I got her involved. Everywhere I go, she goes with me. Not today, she's in school, but everywhere I go, she goes with me. And she's very educated. She's able to help her friends at school, and that's amazing. She's an open mind, and she talks about HIV like nothing. So that's wonderful for me, right? And so in 2008, I went to I heard about the women's retreat at Christie's Place. And what is that? Like Jay said, I never went to one of these. I was always in my home, fighting with my husband, having all these struggles in my life, or using, hiding from my own self. So when I heard about this, I'm like, let me go and see what is it about. So when I went there, I remember next morning I saw these like 40 women in that retreat that I was like, oh my God, I thought it was only me being positive, right? And I saw staff members hugging each other, hugging us, and giving us just the comfort and the love that they really projected for us, and just let you know and let you feel it. And I fell in love too with them. And I was so grateful to be part of that one of the staff members offered me a job, and I'm like, no, this is my first time. I don't know how to speak English. I don't know how to use a computer. So they told me, think about it. I'm like, okay, I'll think about it. But because they saw me talking to this group of ladies. And so next year I went again, same thing, very emotional, very happy to be part of that. And they did offer me the job again, and I'm like, no, I can't, I don't speak English. So they said, okay. So that was in September. For January 19, I started working at Christie's Place as a peer, as a family kids worker, but a year later I started working as a peer navigator, and that's the best thing that happened to my life. Because Christie's Place changed my life. Until now, it keeps changing my life. Just having the opportunity to learn and help other women like me, letting them know that they don't have to stay in that hole. They can come up and be them. They don't have to face domestic violence like I did. They don't have to be using drugs just to feel that they're lonely. They can be mothers. There's a lot of things that we can offer them just through the education that we had. And also when I talk to my clients, I always say, if you're here at Christie's Place for the first time, it's like being in Disneyland. I always say that. Because as peer navigators, they let us do whatever we want with them. And we're talking about being under care, offering some resources about how to stop domestic violence, substance abuse, just being a better mother. I mean, we offer everything they need. Just accompany them to their doctor appointments. It's huge, because many of those ladies, they don't speak up. They just go through their doctor appointments, but they don't ask questions. They don't know they don't even know their labs, if they're undetectable or not. What does that mean? So we're able to be there with them and just ask the doctor, or ask them, can you ask your doctor about your labs? It's a way to teach them how to speak up. And for me, that's huge, because I never had nobody with me to show me that way. So being not only a peer navigator, but a guidance for them, it's big. That's why for me, being part of Christie's Place, it's a blessing, right? Helping these women understand their barriers, because many of them, they don't even know that they're going through those barriers. They don't even know that they have rights, right, to move on, to be out of that relationship if it is not good for them. Just being part of Christie's Place, it's an open door for a different life, and I'm just grateful to be part of that. And I just want to say thank you to the two people that are here that I'm just very grateful to give me that opportunity to be able to change other lives. Not only them, those ladies, but my daughter has seen all that, and that's amazing. I know now, after all this education, that barriers have solutions, and that's what I share with my clients. And that's because Christie's Place, it's educating us to educate others. And I think that's all.
That's
Thank
great.
you.
Thank you. Thank you both for sharing your stories and the impactful work that you're doing at Christie's Place. I think now we'll open it up for questions.
Changed in the people and the stories that you've heard over that time?
Not really. So the barriers are still the same. Women still go through the same issues that, the domestic violence, the substance use, and the undiagnosed mental health issues. We had, like Jamila was saying, we have a long way to go in treatment and in assisting these people, these women, be retained in care. And, So, we're still fighting the fight to make changes, just by educating women, and in that way, hopefully, they'll educate other women in their community.
And I'd like to add that, Christie's Place is very, very unique. We presented on the work that we're doing, our academic community collaborative relationship at the National Conference on Health and Domestic Violence in September. And so we shared, a sneak peek as to what our intervention entails, and the intervention's basis being based on peer navigation. And it was amazing because the feedback that we received from attendees across the US was that how can we replicate this in our community? Because there's a lot of agencies across the US that do not have the benefit of even learning from Martha and Jay and leadership such as Dr. Falvey at Christie's Place. So that goes to show you that we are doing some great work here in San Diego, and Christie's Place is viewed as a model for across the nation to other community-based agencies. Any other questions? Sure.
Yeah, I mean, it sounds absolutely amazing, and I'm wondering if you think it's possible to translocate this model to non-HIV positive women. They suffer from the same issues of addiction and domestic violence, and if it's working so well in the context of HIV, do you think it would be possible to help other women?
Yeah, I'll get it. So yes, it is possible. It's just the resources to be able to do that. Utilizing Christie's Place as a model example and looking at domestic violence agencies or mental health providers or substance abuse facilities and integrating like an integrated HIV prevention and treatment model within those settings is key as well. So yes, it is possible. It's just the funding to do that is needed.
Jay, Martha, what amazing job, first of all. Your story inspires me each and every time that I get to hear it, and I hear a little bit more of your journey, and I'm incredibly privileged to get to work alongside both of you. But we're starting this new amazing Empower project. Would you be open to sharing a little bit about what it's been like to do the pilot studies?
So Empower, that's one of my favorite programs or projects because for me, it's like working with the clients more closely, more deeper. So right now we're doing a pilot group. So this is for 6 women, and every week we're doing for 6 weeks we're doing a class. So we are educating clients about all these issues and traumas and all the struggles that they go through. So this is more about giving them some solutions about what's going on in their lives and kind of detect their feelings and what to do with it. Because for me as an addict, I can say that was my struggle. I didn't know what to do with my feelings. That's why I used to drink. That's why I used to use drugs, because I wanted to just numb my feelings. So this project is helping them to kind of, detect that or see why they feel like they do. Why do they accept stuff from other people and make them feel down? So I think this is a great project that helped them to grow up. And this is our second group that we have. And on the first one, we have one person that totally changed her life because she understood what was not right, on her life, and was able to just change that. So we kind of open hearts and open mind for them. And that's huge. Because, people have to be open and ready for those changes. And so I see that this project, that's what it does. And I just love it.
Yeah, Empower is a great intervention. it teaches, like Martha was saying, all the stuff Martha was saying, and you know, it empowers the women. It they learn their rights to feel, think, act. Um, and so the second pilot that we have going on right now, we have 5 women, and some of the women are teaching their families the tools that we're teaching them. And so, like focused breathing and self-care. And so they're working with not only is it working for them, but it's working for their families as well. So it's a great intervention, it's working. We know it works now. And hopefully we'll be able to change a lot more lives.
Thank you, Jay and Martha, for your stories. They're really inspirational. And one of the messages that I felt came through so strongly in both of your stories were the personal connections that you had when you started working at Christie's Place and were first, felt that love you both talked about, and then now the connections that you as peer navigators are able to meet with people as you help them along their journey. And I was interested reflecting on that with what Dr. Stockman was talking about regarding to, novel interventions and things like mobile apps, which can obviously help in a lot of ways, contact people, remind them. And I was wondering, within the context of these personal connections, what the response is among these women for these, mobile or app devices, and what they want to use them for. What do they see the potential for in terms of, putting that in context of course, the amazing work you do developing those personal relationships?
First, it lets them know they're not alone. We build almost a friendship. We're able to connect with a woman on a level that a doctor can't connect with them. We're able to relate to the woman's situations because we've been through the situations. They want to change their lives too. They want something different. And so they appreciate having a friend, having someone they can talk to. We got cell phones, they can call us, we text them to remind them of their meds. We work with them on a personal level to show them that it's okay that you're HIV positive, to show them that it's okay to accept your diagnosis. It's okay. It's not the end of the world, and it works. It helps a lot.
I think we practice a lot empathy with them. And for my clients, I always tell them that I can be their mother, their sister, whatever they want to call me. But it's for us, it's very important to, kind of build that relationship with them so they can trust. And after they trust, they believe in us, because sometimes they go to their therapy, they don't even share nothing with them, but they're able to share a lot of stuff with us or with their doctors. So it's very important for us to create that relationship very, very tight.
And I'll add, our funder asked us that question, Natasha. So, and we responded. For women facing these barriers, these very sensitive topics, the mobile app is probably not the best method in terms of achieving the goals that peer navigation achieves, because they really like the in-person connections. Now, sustaining the connections and, especially the connections that they make at Christie's Place beyond peer navigation, technology probably would be useful for that.
I wondered if you could talk a little bit about the California HIV research program. They've put a lot of money into funding Disparities Core, Disparities Cores at the 3 CFARs in California. And how do you see that going? And is that unusual? Are there other states that also are putting that support into disparities research?
Sure. So the California HIV/AIDS Research Program, they have put a lot of money into funding 3 Disparities Core at each of the CFARs in the UC system. So UCLA has one, UCSF, and us here in San Diego. And each CFAR has been funded to support not only the Disparities Core, but 1 to 2 research projects, interventions, innovative interventions that address HIV-related disparities when we think about prevention and treatment. And our core here is the projects funded were Empower Women, which Martha and Jay spoke about and I spoke about a little bit, and another project called IC Change, which is led by Dr. Moore in the Department of Psychiatry, and his project is focused on implementation of text message reminders to remind patients to take their meds. So his primary outcome is what he hopes to achieve is improvement in ART adherence, and his target population, his sample is he's collaborating with Family Health Centers of San Diego for that project, and the focus is African American Black individuals. So it's culturally tailored text message system that he's created. The goal of this whole initiative around HIV disparities is not just to have researchers conducting the research, but really partnering with community partners, local community partners in each of the 3 regions, the three cities. And so each project forms this academic community collaborative relationship. Other projects that are occurring in the UCSF and UCLA sites involve, one is Links, the one I mentioned with the mobile app, and another project in San Francisco focuses on the house and ball community, so a very marginalized community in San Francisco, and utilizing members who attend, these house and ball events to create an intervention, and it's a peer-based intervention as well. So the themes that I've seen across all of the projects are the utilization of technology, peer navigation, and let's see, I think those are the two main themes, and really targeting some of these underlying factors that I highlighted under missed opportunities to really address and improve HIV care and treatment outcomes. And all those projects focus on people living with HIV in California.
So I just have a quick question. What are some of the challenges working as peer navigators at Christie's Place, or if there are any? And what are some themes that you guys are seeing as barriers for the women that are there?
I think what we see the most is mental health, drug abuse, domestic violence also, but I think mental health is one of the biggest ones. So, because we know they're not ready, but we're still trying. So we follow up with clients, but that's all we can do sometimes.
Hi, so thank you so much for sharing your story. I really like to listen to you, that's so empowering. I have one question. Is there a particular type of women that you have the feeling is more receptive to your intervention? For example, women with small kids, or younger women, or like a particular phenotype of woman that you feel it's like your ideal intervention candidate?
I don't think so. I think it just varies across the spectrum. No particular, all the clients are different. So I don't think it's any difference.
Jay and Martha, I just want to thank you first for sharing both of your stories. I am honored to be able to work alongside you every single week, and every week I am constantly inspired by both of you. And you give me a sense of passion for this work, and I just am so grateful to know both of you. And thank you for sharing your stories. I wanted to ask, and so that you could share with the audience, how much trauma is part of the stories, whether in your own stories or in the stories of the lives of the women that you work with, and how that is really the foundation, possibly the foundation for some of the mental health issues or substance issues or alcohol that they are facing, and how Christy's place is trauma-informed and how you are able to bring that into their lives.
I think also that, like we said before, it's different on every person. But for my own experience, I could say it's trauma in my life, it was 100%, right? But when I got educated and I learned that I can change that, right? And when I did that, it was just attending therapy, learning about myself, and just seeing my life in a different way. And I still, at this time, even that I'm 12 years clean, I still attending those programs. I still going to my therapy. I still doing a lot of changes in my life. But having that trauma informed in my life, it's also one tool that I really wanted to keep in myself, because I still learning every single day. And that's one of the things that I really like, because it's been changing my life, day by day. So being able to have all that in my position and being able to share with my clients, I just offer them that. And some of them, because I want to say there's a lot of successes that we have, some of those ladies take those tools and they change their lives. But with the clients that I work with, I think they all go through with trauma in their lives. But they learn, step by step.
Like Martha said, all of our women have had some sort of trauma, just like we have. Childhood trauma, adult trauma, current trauma. So we really work hard to meet a client exactly where she is. And we don't want to re-traumatize her. We don't want her to be on edge with us, so and back away from us. So we have been trained to do trauma-informed service provisions, and it works for the client. It worked for me just learning, because I didn't know about my trauma, and it taught me a lot, about my mental health state. So I was able to learn about me, and in turn, I'm able to share with my clients what's going on with me. And we can relate. It's similar. And that's very important.
I think we, one more or no? Have time?
Thank you very much for your presentation. That was very brave of you to come up here and tell your stories. We really appreciate it. And along that line, I would just like to know, for healthcare providers and scientists who haven't necessarily walked in your shoes, sometimes in trying to provide care for people that are having the kinds of difficulties that you described, it can be frustrating when they don't take our advice, for example. And I'm sure in your own situation, you've worked with a lot of people who also didn't take your advice. Do you have any advice for us on what motivates you to keep going and, to keep trying and to not give up on people like that?
I think what keeps me going and trying is I know change is possible. I know that at some point, if a woman is willing, she'll take your advice. If she's not afraid of the provider, because it's like that hierarchy, the provider's up here, I'm down here. And so, and that's part of what we do. We work with a woman to overcome that. Just meet a person where they are. You know, treat them like a person, not just a statistic. You know, yeah, they're your patient, but they're human. And, you know, you have to get that human connection.
For me, what keep me going, well, there's a lot of things, but I think the first one is my own self. Because when I decided to change my life and see my transformation, you know, I was able to see that I'm a miracle. And I have a daughter, like I said before, I want to be a role model for her. Not only, you know, because life is hard, so she can make right decisions after she see me on this transformation. And now working at Christie's Place with my clients and see the transformation with them, that make me feel like I have to keep going, you know? Every time I see a woman getting out of that relationship with domestic violence and change their lives and telling me, Mrs. Martha, I want to be like you. And next appointment, I see her, yes, like, sometimes dressing yes like me. So that's, you know, that's a success, right? Yeah, that's huge. That tells me that I'm doing the right thing, and that you know, tells me that you're doing right. You have to keep doing what you're doing. But most of it is me, because I thought I will never change my life. I thought I was going to die using. I thought I was going to die by AIDS, and I'm here after 17 years. So that's why I need to keep doing what I'm doing and keep educating myself so I can transform those people, women in the community, because we need a lot of help. So we just two of us. We need more people to help, you know. But it's the community. We're not doctors and we're not nurses, but we're positive. And doing what we're doing, we can change something out there. And maybe one day the next conference could be there's no more positive people around, right? And that's what keeps me going on.
So I guess we're out of time for questions. Right? Move on. Okay. Thank you all. Thank you again, Jay and Martha. Thanks so much. There are 3 housekeeping items that I need to share with you. Please make sure you sign in if you haven't already, and you will be receiving an online evaluation for today. So please make sure you complete that. It'll inform us and let us know how we're doing and what we can do better. And then finally, restrooms. There's restrooms in the back, and I think they're downstairs too. I don't know. Kim, there are restrooms downstairs as well? Okay.